First of all, I would like to thank the organizers and the panel for the invitation. And I'm very happy to talk about cardiovascular biomarkers and myocardial injury in particular in patients with COVID-19. And I will also give you a brief overview of our own research findings in this subject. I do not have any conflicts of interest to declare. When we talk about cardiovascular biomarkers in patients with COVID-19, we have to consider that there has been quite a bit of research in this matter. We have several biomarkers that have been identified to be of prognostic value in these patients. These are just a selection of a few regular ones, common ones used. We have high-sensitive cardiac troponin I or T as a marker of myocardial injury, NT-proBNP as a marker of natriuretic peptide. Of course, there's D-dimer, which is linked to thrombosis and thromboembolism, and then some other less used biomarkers. When we're talking about pathophysiology of myocardial injury in patients with COVID-19, I think we have to consider the fact that we do have lots of hypotheses, we do have lots of potential mechanisms that might explain this association. However, we do not have any direct causal relationship that has been identified yet for this association. Just to name a few without going into detail, I think we can look at oxygen supply-demand imbalance. We can look at inflammation-related injury to the heart. We also have to consider micro and macrovascular thrombosis and thromboembolism, and also, of course, direct viral admission to the heart. So this is just one of many studies published on this subject of myocardial injury in patients with COVID-19. We do know from meta-analysis that the true prevalence of myocardial injury in these patients, especially among hospitalized patients, is roughly about 15 to 20%. We also know that the outcome of these patients is significantly impaired. Now, we again look at a meta-analysis that summarizes these findings, and we can see an almost universal finding of increased mortality among patients with higher levels of cardiac troponin I or T. Now, this leads me to our own research findings, and I'm happy to show you a brief overview of our study that was performed in Vienna, Austria, with the title Improvement of Outcome Prediction of Hospitalized Patients with COVID-19 by a dual marker strategy using both high-sensitive troponin I and copeptin. Now, why did we choose copeptin as a biomarker of interest in this setting? Well, copeptin has been established as a biomarker of stress and has been of prognostic value in a plethora of clinical conditions, including pneumonia, critical illness, and cardiovascular disease in particular. I already said it's a prospective, observational, single-center study that was performed in a tertiary hospital in Vienna, Austria. We had a total of 223 hospitalized patients with laboratory-confirmed SARS-CoV-2 infections, so all our patients had PCR done. We excluded 10 patients because of missing laboratory values, and all patients presented to the emergency department between June and November 2020. So we have a good appreciation of the second COVID-19 wave in Austria. The primary endpoint of our study was a composite of admission to the ICU or all-cause mortality within 28 days, and the key secondary endpoint was 28-day all-cause mortality itself. Now let's have a quick look at the baseline characteristics of our study population, and we can see that those patients with an adverse event were significantly older. They also had more comorbidities. This is quite a likely finding. We have more hypertension, we have more history of cardiovascular disease, and we have more chronic kidney disease. Patients who died within the follow-up or were admitted to the ICU also suffered from dyspnea more often. And then when we look at the routine laboratory measurement in these patients, we see a strong inflammatory axis. We see higher levels of white blood cells, higher neutrophil granulocytes. We also see a higher neutrophil to lymphocyte ratio. We have talked about that today already. Of course, CRP as well. And also creatinine and LDH, both markers of risk in patients with COVID-19 that have been well established before. So what are the results of our study? Just one quick look at the levels of troponin and copeptin show us that both biomarkers were significantly increased in patients with an adverse event. Now, when we look at the statistical analysis, we did this both on a dichotomized and on a continuous level for both biomarkers, and we adjusted in Model 1 for age and gender, and then in Model 2 for comorbidities and clinical signs and symptoms of COVID-19. And we found persistent, significant results for both copeptine and high-sensitive cardiac troponin I in both groups, both on a continuous level and on a dichotomized level. And we also found that the combination of high troponin and high copeptine yielded in the highest odds ratios of all patients. So what we now propose is a risk reclassification system. I hope you can see it is rather small, but again, we had 213 patients hospitalized with COVID-19. We had an adverse event rate of 25% within 28 days. We then performed stratification of our patients according to levels of troponin first. So those with high troponin had a significantly higher adverse event rate. We're looking at 44 to 45%, whereas those with low levels of troponin were only at 13%. And this is where the copeptine comes in as a second risk stratificator. And we looked especially at those patients with high levels of troponin, and we found that the group of patients with an increase of both biomarkers constituted a high-risk group with an adverse event rate of roughly 55%, whereas those with high troponin and low copeptine had comparable event rates compared to the group of patients with a low troponin to begin with. This association remained persistent for the key secondary endpoint of 28-day mortality itself. And when we look at our graphic, we see again 24 of 59 patients died in a group of patients with high levels of both biomarkers, whereas a high troponin and a low copeptine only resulted in 1 death among 26 patients with this biomarker combination. And again, we have a risk reclassification to low risk according to both biomarkers. Now, what does this mean for clinical practice? First of all, should we do routine measurement of cardiovascular biomarkers in patients with COVID-19? I think this is quite a difficult question to answer, and there is a lot of ongoing discussions about this topic. We do hope that our research findings help the clinician in better understanding increased levels of high-sensitive cardiac troponin I, and maybe even guide adequate treatment or management, and especially monitoring in the early phase of the disease. But we do have to consider that these are the findings of one observational study with roughly 200 patients, so external validation is definitely necessary to make definite conclusions. And with this, I would like to end my presentation, and thank you for your attention.
Many interesting. In fact, there are a lot of questions. I don't know the order. I don't know which is the first. I don't want to make an error. So, first.
Thank you. Excellent paper. It's going to get published. I see it's under review. Congratulations. I did a copeptin paper a few years ago, very similar, and I got spanked at the reviewer who actually made my paper a lot better. So I'm going to give you the same thing they did to me. The most important part here is what they knew in the ER. If in the ER, the patient is going to end up in the ICU, I'll put them in the ICU right now. If they're going to be in the ICU 28 days from now, I don't care. So what I would ask you is how many people went straight to the ICU? Because that means they already knew and the markers wouldn't change anything. But if a third of the patients went to a floor and then went to the ICU tomorrow within 24 hours, they missed it. And the marker would be very powerful because it would make me do something I'm not going to do now. So how many people went to the ER and then to the ICU within 24 hours?
Okay. First of all, that's of course a great point. We had an overall adverse event rate of roughly 25%. And patients going to the ICU on day 1, so on the day of admission to the emergency department, was roughly 7 to 8 patients. So we have a lot of patients that were missed, that did not go to the ICU right away. But of course, this is a potential bias as we included those patients as well, where decision was maybe already made upon checking for the biomarkers. But thank you for the input.
Professor Di Somma?
Christoph, congratulations. It's really very interesting. I'm following up I'm making echo what Professor Peacock just said, because I'm just asking 2 questions. What do you think copeptin is mirroring is ongoing physiopathological mechanism there? Because I'm very clear what is going the high-sensitive troponin effect. Why you chose copeptin? What was physiopathological? And then, second question, what are you doing as therapeutical decision-making? Have these two biomarkers, use beta blockers? This is an important question, because at the end of the day, from my point of view, biomarkers, and now what?
Sure.
That is really my point.
I agree with the second point, but let's start with the first one. So the pathophysiological rationale was that we saw that copeptin is a significant predictor in a plethora of clinical conditions. We looked at inflammatory disease in particular. We have data on pneumonia. We have data on critical illness. We have data on sepsis. And then, of course, troponin being a cardiovascular biomarker, we looked at cardiovascular data. We all know about copeptin and myocardial infarction. We also have data in heart failure. We have data in pulmonary embolism. So we thought that the systematic disease COVID-19 that affects so many organs of our body might be related to copeptin. I already said copeptin, or vasopressin, is of course a stress hormone. It is excreted secondary to hyperosmolarity, so maybe hypovolemia may play a factor as well, because fluid management in patients with COVID-19 is difficult, and this was part of the rationale. But of course, I do not have a clear pathophysiological explanation, as the study was not meant to answer this question. Now, what do we do with our information? And I think that high levels of cardiac troponin are a big challenge for patients in the emergency department. It's difficult to get even an echo sometimes. Of course, risk of infection is there and stuff like that. Now, if we look at our data, of course, single center observational study, we shouldn't make too many conclusions, but maybe we can guide adequate monitoring of these patients. Who needs to go to an intermediate care? Who needs continuous rhythm monitoring? Who needs an echocardiogram right away? And I would say that a patient with high troponin and high copeptin should be worked up in a non-invasive diagnostic way more thoroughly, maybe get an echo, maybe be checked up a little bit more regular, where maybe if our data prove to be correct, we can be a little bit more relaxed. If a patient has a high troponin, maybe it's not too high, it's just borderline, and has a negative copeptin, because we know that these patients have better prognosis. But direct therapeutic implications, I would not take any from these data.
Professor Mabaza?
Just a quick comment. I'm wondering whether troponin really plays any role, because in fact it looks like copeptin is in fact making a difference, because when you see troponin negative, copeptin is probably negative, and you have troponin positive and copeptin negative, and everything goes on low risk. Then my question is, did you analyze just copeptin?
Sure.
And my next question is, then you talked about hypoosmolarity, et cetera, which are not necessarily present in COVID-19. What makes really this increase in copeptin in COVID-19 that is not seen in other diseases?
For the first question, we looked at copeptin as a single variable of interest, and we found that the combination was just of more prognostic value. Both biomarkers were significantly associated with the primary endpoint. However, the combination of both yielded superior prognostic information. We also did net reclassification indices. We did AUC analysis. This is all not presented in the short presentation. And we just found that the combination was better. And interestingly, in patients with low levels of troponin, the prognostic value of copeptin was significantly diminished. I cannot tell you the pathophysiological reasoning behind it, but this is why. But this is an explanation to the first finding. And the second question, I don't know the specific pathophysiological reasoning why copeptin is high. I just know that it is high in lots of clinical conditions, especially among acute clinical care, and this is why we hypothesize this.
Okay. Any question? No, I think time is up, so we can move to the last.
Thank you.